Hey, hello, good evening to everyone. Is my voice audible to all of you?
Yes, doctor.
Hi, yes. So I'm definitely as nervous as all of you to be conducting a session in this kind of mass number. I'm rather comfortable with a smaller group, but I thought today maybe I will just give a try and have some adrenaline rush as much as some of the participants today. So I'm going to choose a few cases that some of those of people who previously joined me before may find it boring, but I thought that since I'm not often with many of you guys, so I'll be sharing some very much important and interesting cases, two clinical consultations and two communication stations. So I've asked Yi Hong to help me because this whole thing is rather complex to me. So I hope that I don't accidentally just press the slide and just spoil the whole fun of the station. So I shall probably begin in a short while. Let me just see. The first candidate is Dr. Chua, right? Dr. Chua, are you ready?
Yes.
Okay, so just to make sure that I'm in the same page with you, it's a clinical consultation. You have 20 minutes, so you have 5 minutes to prepare, and then you have 15 minutes with the patient. I will tell you when you have 2 minutes is left, and typically you have 5 minutes with the examiner to discuss about the case. In the 15 minutes, I leave it to you on how much of time do you want to allocate to the history and examination. But I will just show you some pictures that is relevant. Those that I have not shown, I will just verbally let you know what are the findings. Are you okay with that?
Oh, I thought I'm doing com skill, but I'm okay with clinical consultation.
You're doing com skill?
Yeah,
Oh,
I'm okay with both.
Let me not change the preparation by other candidates. So in that case, I will start with Dr. Eldon first then. Is it okay? So Eldon, are you okay?
Okay, give me 2 minutes, Xin Wei.
Can. So if that is the case, Dr. Chia YW, do you want to start first then? Or you need a 2 minutes as well, since I suddenly start the communication.
It's okay, doctor. I think I can take the clinical consultation.
You can take? Okay.
Yeah.
So I will just adjust a bit. Maybe Yi Hong can just tune with me. Dr. Chua will do the first clinical consultation, followed by Dr. Eldon to do the second clinical consultation. And then Dr. Nick and Dr. Chia YW will do the communication 1 and communication 2 respectively. I'm so sorry, I kind of messed it up a bit. But yeah, is it okay with you?
Thank you, doctor.
Bye, boss.
Okay, sure. Then in that case, I will just follow the arrangement that's been made now. Okay, so we'll begin with Dr. Chua with the first clinical consultation. So are you okay with the format that I've given to you just now?
Yeah, sure.
Okay, so I will put up the scenario. Once you can see it, your 5 minutes begin. After 5 minutes, I'll straight call out your name. Your 15 minutes begin when you start talking, and then we will move on straight to 5 minutes of discussion. Okay?
Okay.
All right, Yi Hong, you can post the first clinical consultations case. Hi, Dr. Chua. Can you just follow me enter into the room? This is Mrs. Maria. You have 15 minutes with her. Your time begins when you start talking.
Good morning, Dr. Xin Hui. Yeah, I will start my session now. Hi, good day, Mrs. Maria. My name is Chua, one of the doctor in the medical outpatient clinic today. I've been received a letter mentioning that you've been concerning regarding your weight gain. Can you tell me more about it?
Oh, doctor, I was very concerned because obviously I find that I'm a pretty much very attractive person, but I find that I've been gaining a lot of weight for the past 6 months. I think about 15 kilo. Despite I don't think I've done anything about it, like eating a lot or eating unhealthy food. So I thought that it may be something unhealthy or something wrong going with me. That's why I went to see the GP, and my GP said that it's better if I get some consultation from the hospital.
Sure, Mrs. Maria. I appreciate your concern. You've been having this weight gain about 15 kg over the period of 6 months. May I know that prior to that, what's your weight?
Previously I'm like only about 60, and now I'm like 70-ish. So it is quite a big jump for me because for the past 3 months, I find that even my clothes are all very tight.
Do you feel like your previous ring doesn't fit your fingers anymore?
No, not until that. Thank God.
Or your feet doesn't fit the shoe anymore?
No, not like that. It's just like, my clothing. I feel that my tummy is getting bigger, my face getting rounder.
I see. Sure. I'm going to help you in a while. May I know that how is your eating habit like? Yeah, what do you eat in a day?
I think my eating habit has not been changing for the past few years. 3 meals a day. Even sometimes I still skip dinner to keep my weight in balance. I eat what usual people eat. I'm aware about healthy diet. I don't take excessively. So as far as I'm concerned, my diet is okay.
Okay, do you take in a lot of like snacks or suppers at night?
No,
Okay. Do you feel like your leg is swollen?
no,
Do you ever feel breathless when you walk to a long distance?
no.
Okay. How about sleeping? Are you able to sleep lying flat?
I can.
Yeah. And is there any occasion that you wake up in at night feeling breathless?
No,
I see. Sure. Anyone tell you that you look more yellowish?
no.
Okay. How about your waterworks? Any issue with your waterworks, Mrs. Mario?
Normal.
Normal. I see. Okay. Do you have any visual problem? Any blurring of vision?
No,
Or you bump into object very frequently?
no.
Okay. How's your appetite like, Mrs. Mario?
I still think that I eat what I usually eat, and I don't lose any appetite. But because of the weight gain, I'm a bit more conscious, and definitely I'm eating lesser now. But I don't think it's helping much.
Okay. May I know that do you have any weather preference? Like you can't tolerate any cold or hot environment?
No,
And if you any harassing of your heartbeat, you feel anxiety,
no,
how's your bowel habit like?
Well, I still think that I can pass motion as regular as always.
Okay, I'm going to ask you a few more private questions. I hope you don't mind because it will help you with our consultations. May I know how's your period like, Mrs. Maria?
Well, I think that is irregular for the past 1 year. I would say that it can come as as quick as 2 weeks time, and it can come as long as 2 months time. Each time it comes about 4 to 5 days, and I use about 2 to 3 pads in each day of my menses, but definitely it gets lesser over the period.
I see. May I know that do you have pregnancy before?
Yes, I'm married and I have 2 children.
I see. How is the pregnant process? Any issue during your pregnancy?
No, of course, doctor will say like I'm on some iron tablets just for building up my blood cells in the body. But otherwise, I don't remember having any particular medical problems in that period of pregnancy.
I see. I'm sorry to ask you this question. Hope you don't mind. Do you have any previous abortion?
No.
Or, okay, sure. I'm sorry for asking that questions. May I know that do you notice any abnormal hair grow over your cheek or your face?
Oh yeah, I thought that I have a little bit more extra hair now over my tummy and a little bit more as well over the face. It's kind of pretty embarrassing because sometimes it may make me look like a man, and that's why I have to shave. I'm not sure like if there's anything related to the problem that I'm facing now.
Sure. Do you notice a lot of acne over your face as well?
I don't really notice that. I always have acne, but I don't think it's anything more than the past.
Okay, sure. I'm going to run through a few more questions. Just to complete. Just hope that we don't miss anything. Do you have any headache?
No,
Any nauseated feeling or vomiting episode?
no,
Any tummy pain?
no.
You feeling also in the letter also mentioning that you've been feeling tired as well when you start exercising. Can you describe more about it?
Well, it's just the motivation. It's not like I don't have the energy, but it's just I don't feel like doing extra more. It's just like after the work, I just feel like going back and just lay down and not doing anything. It's been there for the past few months. I'm not too sure what's the reason that happens to me as well.
Do you ever passing out any blood over your stool? Any blood in your stool?
No,
Any blackish stool?
no.
Any bleeding over your any parts of your organs?
How do I know that, doctor?
Any nosebleed, gum
No.
bleeding, any
No.
ear bleed, any bruises over your body? I see.
I find that maybe sometimes I get bruises a bit easier now, like when I knock on something. But I don't think I bled like what you are saying.
Okay, but then you don't oftenly bump into object. You just occasionally bump into object. Is it right?
Yeah.
Okay, sure. Do you have any rash over your body?
No,
Any joint swelling or joint pain?
no,
Any rash after you exposed to the sun?
no,
Okay. Any ulcer over your mouth?
no,
Any lumps and bumps over your body?
no,
Any high spike temperature?
no.
Okay. Do you ever feel like you're excessively tired in the morning that you want to feel asleep again?
No.
Do your family member heard you snoring at night?
No.
Do your family notice that you ever stop breathing at night as well?
No.
Okay, sure. Thank you. Okay. May I know that do you have any allergy, Mrs. Maria?
No.
Okay. Are you taking any medication currently?
Just some vitamins from the counter. Nothing much.
Okay. Do you ever take any drugs that you purchase outside from the doctors?
Yeah, just some vitamin tablets, as I've mentioned.
Any steroid medication? Any to boost your
Steroids?
strength? Yeah. Any medication that you purchase outside to boost your strength or immune system?
Yeah, vitamins, as I said. Steroids. I'm not too sure what is that.
I see. Sure, no problem. Do you have any previous medical condition?
No,
Okay. Have you done any surgery before?
no,
Okay. Okay, sure. May I know that is there any medical condition running along in your family members?
Well, I think both of my parents are still well, alive, and they are currently both of them are residing in Italy, enjoying their retirement days.
I see. Sure. I'm going to ask you a few more specific questions. Is there any one of your family member having any cancer?
No, not that I know of.
Any one of your family member having any thyroid problem?
Thyroid?
Yeah, a glands over your neck that produce excessive hormone that make, yeah. Have you heard of the word thyroid before?
No, no.
Okay, sure, no problem. May I know that Mrs. Maria, do you smoke?
I don't.
Okay, do you consume any alcohol?
Yes, I do. 2 glasses of red wine every weekend during the holiday.
I see, sure. I'm sorry to ask you this question. Do you take any recreational medication?
Oh, of course not.
Okay. May I know what do you work as, Mrs. Maria?
I'm a laboratory technician.
I see. How is this situation affect your job?
No, it's not affecting my job, but it is affecting my family a lot, doctor.
Can you describe more about it?
No, nothing much. It's just that maybe in the past, I can probably have a better time with family, intimate relationship. But of course, now with this whole build and change in my body size, I'm very embarrassed, and that really affect my relationship with my husband.
I see. I'm sorry to help that. We are here to help you as much as possible. Okay, may I know that do you take any birth control pill?
No.
Okay. Okay, sure. I'm going to examine the patient. Yeah. Mrs. Maria, I'm going to ask for your permission so I can examine you. Is it all right?
Sure.
Okay. I'd like to check the patient body weight and height.
Well, I think you can see the patient in general, the build now.
Okay, sure. Is there any cross features over the hand, any sweating palm?
No sweating palm.
Okay. Okay. How is the pulse like?
86 beats per minute, regular, good volume.
Okay. I noticed that the patient blood pressure is high as well on the consultations. Okay, so I go move towards the face. Okay, I'd like to check for any. Sure, no problem. Any hirsutism features over the lips areas?
Well, there's some hair, facial hair over the male hairline.
Male hairlines. I see. Sure. Okay. I want to check the mouth. Is there any mouth ulcers?
No.
No. Okay. Sure. Ask permission to expose the patient abdomen region. I have to perform an inspection of the abdomen region to look for any striae, any scars. Yeah. Okay. 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 Sure. I like to palpate the abdomen. Perform a light and deep palpation and palpate for any hepatosplenomegaly. And
No hepatosplenomegaly.
Okay. No ascites as well, I assume.
No ascites.
I try to ballot the kidneys, or I try to feel any organ over the iliac regions or the suprapubic regions.
No ballotable mass.
I try to auscultate the abdomen to look for any bruise.
Can skip that.
Okay. I like to check all the armpit region for any excessive hair growth as well.
Yes.
Okay. Is there any acne over the face and the frontal chest region and the back?
As shown in the picture.
Okay. So there's no any acne.
2 more minutes.
Okay. May I know what's your concern, Mrs. Maria?
So what is wrong with me, doctor?
Mrs. Maria, I think that we are suspecting that there's one condition that one of your hormones in your body is imbalanced, causing all these problems. We should call Cushing's syndromes. But to mind the term, I will need to do further blood tests and a few imaging to confirm my diagnosis, and I get back to you as soon as possible. Is it all right?
Okay.
Yeah, is there any other concern, Mrs. Maria?
So, like, as of now, do I need to get admitted, or I can just see you back in the clinic after that?
Okay, Mrs. Maria, your blood pressure is slightly on the high side. So I need to give you some medication to control your blood pressure first before you can go back home safely. But in the meantime, if your blood pressure is not controlled after I prescribe you the medication, I may need to admit you. Is it all right?
Right, right. I'm not sure what terms you said, and yeah, like you said, I can't be worried too much. But roughly, is it cancer, doctor?
Okay. Throughout our conversation, cancer is not our topmost thoughts, but I will try to find it out and I get back to you as soon as possible. Is that all right?
Right, right.
Okay, thank you, Mrs. Maria.
Right, thank you, doctor. Right, time's up. So Mrs. Maria is leaving the room now. So Dr. Chua, what is your diagnosis?
I think that this patient likely have a Cushing disease. Yeah, which I need to investigate further, doctor. My other differential including a PCOS or a congenital adrenal, it cannot be. But my other differential diagnosis including a PCOS. But otherwise, I cannot reach any other differentials for this patient.
Right. You mentioned about Cushing disease. What does it mean actually?
Excessive production of the cortisol hormones that is not
Due
from
to the
gland. Some other place, maybe a primary adrenaloma or primary adrenal carcinomas, that's causing all this excessive production of the cortisol hormones.
Okay, so what could it be the difference between Cushing syndrome and Cushing disease then?
Cushing syndrome, as far as I understand, that is the problem lies within the pituitary glands. That the pituitary gland is the one that produces a lot of NgSH, then causing a lot of excessive production of the cortisols. While Cushing disease can be primary, it's just not because of the pituitary glands.
Okay, is there any possibility that it's not the pituitary or the adrenal gland, but it's due to some other organ problems?
Possible.
In this patient?
Yeah,
what
possible.
Possibilities could it be then?
Can be or the small cell carcinomas or the lungs.
So do the patient present of anything like that?
Throughout my history, apart from the feeling tiredness or the exercise, I didn't manage to get any symptoms across the lung yet.
Okay, all right. What investigations would you like to order?
So first, I need to confirm my diagnosis by checking the cortisol hormones. I like to check the serum M cortisol. Then I would like to check the serum cortisol. I like to check the NgSH as well, followed by other baseline blood investigation, including your fluid blood count, liver function test, renal profiles. I also will order a CT abdomen to look for any primary adrenaloma, any primary adrenal growth tumors. Yeah. Otherwise, I will also do a oral dexamethasone suppression test to check for the cortisol, is it suppressible?
Right, right.
Check the fluid counts, check for the glucose as well for these patients.
If this is proven to be adrenal hyperplasia, what is your management?
It's a multi-team disciplinary approach. First, I will educate the patient regarding his conditions. Subsequently, I will engage my endocrinologist, whether and discuss whether this tumor is actually resectable. So if this tumor is resectable, I consult my breast and the endocrine surgeon to prepare for adrenalectomy. In the meantime, provide patient supplements of the cortisol hormones.
Right. Okay. All right. I don't have further questions to ask. You have actually another 30 seconds left. We shall end the session. Is it okay?
Sure.
All right. So you discussed for the case. So, but before that, how do you feel about it, Dr. Chua?
It's a bit difficult because I don't know. Yeah, I thought it's acromegaly because in my mind it's like weight gain, tiredness, high BP should be acromegaly. Then my mind kind of fixated toward that part really. Yeah. Then turn out it's not acromegaly, so it's some other things. So I'm trying very hard to find it. Yeah. Then I thought it's PCOS as well, but then it doesn't look like it. Yeah. So yeah.
Right. Yeah, I'll just share with you some points. But overall, I think you did well in terms of the history taking, where I think is complete. You're able to give some possible differentials, relevant investigations, and what is necessary in the management. Overall, I think you would have had a clear pass in this station. But just a few take home and some tricks that I can share that can be applied in the general aspect of communication, clinical consultation. Right. Number one is on the chief complaint. So always try to elaborate the details of the chief complaint before you move on to the systemic review or any relevant negative history. Example, if this is a case of weight gain, you would first explore about what's the distribution of the weight gain, the increment, diet, like what you have done. So the details of it. Sometimes, example, you have a case of headache. Before you really move on to increase intracranial pressure, the causes, just explore what I usually do as anything that is related to a pain, I use Socrates. Whether it's a chest pain, or whether it's a headache, or whether it's anything. So that's what I mean by looking into the details of the chief complaint. Then look into the other history of presenting illness. Like in this case, lethargy, you want to go into that. Then you can go through your relevant negative history and systemic review. That will ensure that you do not miss out anything and cover as much as possible. In the past, when we do basic clinical consultation in station 5, we usually ask targeted history in the systemic review. Example, if I'm thinking of connective tissue disease, I will ask about oral ulcer, and when I don't have it, I usually will move on. But as now, we have increased the time to 20 minutes, so there will be a little bit of fusion where you may ask more to what connective tissue before you really conclude that it's not there. I find that you have a very good way of asking that is open question. We usually advise candidate to say things like, do you have any change in weight? Do you have any change in bowel opening? Do you have any loss? Do you have any change in appetite? Rather than asking questions like, do you have any heat intolerance, cold intolerance? Do you have diarrhea? Do you have constipation? So that will not look so good. So I think you have applied some of these principles in your history taking, which is something that you want to keep it up. Hormonal problems is better said as any change due to some changes in the chemicals in the body. That's how we describe hormonal problems. So thyroid means that there is some chemicals that is produced in the middle of the neck. It can be excessive, it can be too little. That's how we usually say thyroid problems. Whereas for your adrenal problems will be some chemical disturbances due to some release in the organs that is sitting above the kidney, because usually people know the kidney, but they usually do not know the adrenal gland. So that will be just how to explain the diagnosis. Explaining diagnosis is like part of your communication that is being tested, where you are advised to not use medical jargons. You realize that at the end of your session, you have about 30 minutes of very awkward silence. So my advice to candidate is to make you look that as if you have practiced this station for 1,000 times, that you're so good in managing your time that you just finish it right at the dot, although you actually play a bit of goring. So imagine you actually have a pause of 30 seconds and then suddenly you wanted to ask about menses or what. It looks very odd. So I would advise to avoid any long time silence. Instead, take the opportunity to summarize the case if you have time. I don't usually advise people to summarize because it's better to do active things than to summarize. But if you really do have time, you can always say, so, Mrs. Sandra, so from what I've spoken to you, you seem to have this, and we come to this, and we're going to do this. So that will save you some time and make you look finished exactly on the dot. That will really look good. In terms of the diagnosis, this is the reason why I wanted to share this case with all of you. When we have something that is a giveaway, like you from far you see, you know this is definitely a Cushing, or something like when you see from far, you know this is a thyroid mass. Definitely, you need to do better because this principle diagnosis, etiology, complication. So in PACES, if you can, of course, you must get is the diagnosis. That is for sure. But once you get diagnosis, you must always remember that there is etiology. So you need to explore etiology. For example, you see a neck mass and your diagnosis is hyperthyroidism. But what is the etiology? Is this grave disease, or is this the early phase of Hashimoto, or is this a toxic multinodular goiter? So etiology is important. Then after that, complication. So what is complication? Example, thyroid cardiomyopathy, grave ophthalmopathy causing exposure keratitis. Now, while for this case, it's definitely a Cushing, but the etiology that the examiner would like to look to see whether will you explore further into it. Is this a pituitary problem? So I think when you ask for vision, you wanted to look hard for acromegaly. So it's kind of forgiven. I mean, it's kind of like already covered as well for my pituitary problem. So that's okay. But I just want to make sure that you actually did think about it. Like you want to look for pituitary problem. Adrenal. So adrenal hyperplasia, adrenal carcinoma. So when you ask about change in weight, I hope that you're thinking about that. When you think about oat cell carcinoma, ectopic ACTH release, I hope that when you ask about hemoptysis, any cough, any respiratory symptom, you're interested actually to find out about that. So that is what I mean by etiology. If I would like to make this case a little bit more interesting, then always remember, when you have something like Cushing or high blood pressure, make you think of pheochromocytoma, remember about Men's syndrome. So screen through the other components of Men's syndrome. So this is one thing that I need to advise of you. If you do see a patient with diabetes, I always say the 4 great giants. I mean, not I say, it's during our practice, and I'm sure that if any of you are still when you're practicing with other people, you will always remember this, the 4 great giants. Addison's, myasthenia gravis, rheumatoid arthritis, Addison's disease. So once you have any of autoimmune disease like diabetes, thyroid disease, always remember the 4 great giants, and therefore you have to exclude them in your history taking. So that is all I can share. I hope that I just want to emphasize to all of you is when you think that you get the giveaway of the diagnosis, do not stop there, but remember about diagnosis, etiology, and complications. So like example, in this case, let's say if there's adrenal mass, then you think of complication, like example, can there be any compression over the structure, any pain, any bowel symptom? So this is complications. So if let's say you have a case, let's say it's a hemochromatosis, and the patient actually trying to sell you with some diabetes, don't forget to talk about micro and macrovascular complications. Okay, so is it okay with you, Dr. Chua?
Yeah, doctor, I learned a lot from you. Thank you so much.
Right, so that will be the first station. It's really a giveaway, but I think you really did well that you have covered as quite a lot of things. Okay, so now we'll go on to the second station. I'm not sure now. The second station will be taken by whom? Okay, this is just a sharing on the components, the etiology. So you have tried to exclude many of them actually. Okay, right. I think we don't go to the next slide because I think the next slide will be the next case. So who will be doing the next case?
Is it me?
I think so. Okay, so Eldon will be doing the next case. Okay. Are you ready, Eldon?
Long case, right?
Yes, clinical consultation.
Okay.
Okay, so just recall again, you'll be given 5 minutes to the case, and you have 15 minutes with the patient, 5 minutes with the examiner. You'll be told your 2 minutes remain at your last 15 minutes, and then you will go straight into the discussion. Are you okay with that?
Yeah, okay.
Right. So once you can see the slide, your 5 minutes begin. Your time starts, okay?
Okay.
Hi, Dr. Alden. Please come. Can you just follow me into the room? So this is Mrs. Sandra. You have 15 minutes with her. You'll be told when you're left with 2 minutes. Your time begins when you start talking.
Okay, hi, good morning, Mrs. Sandra. I'm Dr. Eldon here. I'm one of the doctors in the clinic today. May I confirm that you are Mrs. Sandra Billington, 59 years old?
Yes, I am.
So, Mrs. Sandra, so we are here to talk about your medical condition. So, can you tell me, I've received a letter from your GP saying that you have suffering from this itchiness. Could you tell me more about this?
Yeah, this itchiness has been there actually like for past 1-2 months. I've tried all kinds of things, calamine, loratadine, doesn't help at all. So I went to the clinic, and as the doctor said that since it's been poorly controlled, that's why they asked me to actually see you.
Okay, so Mrs. Sandra, I'm sorry that this has happened to you. Hopefully, by the end of this session, we'll be able to get a diagnosis for you and to help you as well. Is that okay?
Sure.
Okay, so can you tell me more about this itchiness? Can you tell me that you have mentioned that it started 1 to 2 months ago? Does it started suddenly or started something very slow?
I think it's very slowly. Like initially, it's just over some areas over my neck, but now it's like even over my tummy, my thigh, my hands. So it's getting more and more, and it's more frequent, more often, more intense.
Okay. Apart from this itchiness, do you notice any changes in your skin, like reddish or bumps in your skin?
No,
Okay. This itchiness, does it occur throughout the day or does it happen on and off?
I think it's just all over the day.
All over the day, okay. Do you realize that anything that you do makes it better?
No, I don't think so. It's just I just need to bear with it and then just hoping that it gets over. I don't think any medications, whether it's applied or whether it's consumed, is helping.
Okay. Do you realize anything that helps it uh, in your condition?
Sorry?
Do you notice that anything helps it relieves the itch?
Yeah, as I said, almost nothing.
Okay, all right. So I have further questions from you. Bathing in a hot shower, does it aggravate this itch?
No,
Okay. Does this itch disturb your daily function, Mr. Sandra?
a lot. I guess I'm getting more inhibited from socializing because it's very embarrassing to be scratching all over when I'm meeting my friends.
Okay, all right. So, all right. Okay, so Mr. Sandra, do you have any coughs or difficulty in breathing along during this period?
No cough, no shortness of breath.
Okay. Any chest discomfort?
No,
Okay. Do you any racing of the heart you feel?
heart racing? No,
Yeah. Do you wake up in the middle of the night feeling breathless, or do you need extra pillows to sleep on at night to help you?
no,
Okay. Do you suffer from any changes in your bowel habits?
no.
Okay. Do you realize that your skin is one of your family noticed mentioned to you that you look more yellowish than usual?
I didn't notice it, but I think recently when I went for tattoo for my eyebrow, apparently the person who helps it said that my eyes are a little bit tinged of yellowish color over my white part of the eye. I'm not sure how it happened and when it happened, but that's what I noticed.
All right. So may I know when did you did the tattoo? How before the itch or after the itch?
It is just also the past few months, recently only.
Oh, okay, sure. All right. Do you notice any change in your weight?
Not really. I just find that maybe I lose like 1-2 kilo because of the itch. My mood not good. It's lose a little bit of weight, but I'm not so gross.
Okay, all right. Is there any problem? Do you have any problems with swallowing?
No,
And any throwing out of food, vomiting?
no,
Okay. Is there any headaches?
no,
Is there any you feel dizzy more frequent during this period?
no,
Do you feel your hands and your feet, you feel like numb, or you feel something uncomfortable sensation?
no.
Okay. Do you feel any pains in your joints or over your back?
No, just
Okay.
I do have some back pain,
Okay.
but I don't have any other joint pains.
Okay. Can you tell me more of this back pain? How did it start and all?
I think it's just some sports problem. I'm a very active sports person. So in the past, of course, I do have some active sports game and then some sprain here and there. So I do have some back pain, which I just occasionally just get some medication to solve it. But I remember that I don't have this back pain for the past few months during this itchy problem actually.
Oh, okay. All right. Do you wake up? I mean, do you realize your back is stiff usually in the morning?
No, that's fine.
Okay. Okay. Sure. You mentioned that you don't have any change in your weight, right?
Just 1-2 kilo, I told you.
Okay. Okay. Sure. So sorry. Going back to the rash. Is this the first time this occurred to you?
Yes.
Okay. So, Mrs. Chandra, I just want to ask some few questions. Some of them might be sensitive, just that I would not to miss out some of the things to help me in the diagnosis. Is that okay?
Good.
Okay. Do you have any previous medical conditions in the past?
Yes, I am still having this problem. I have these low thyroid hormones, hypothyroidism, I think it's called. About 10 years from now, I used to have depression, and I'm still having it, but it's better controlled now.
Mm.
And I also have appendix removed 5 years ago.
Sorry, 5 years ago.
Yes.
Okay. Do you take any medications along with these conditions?
Yes, I'm currently on imipramine given by the psychiatrist, thyroxine by the endocrinologist, and I do take some ginkgo supplements from the counter. That's all.
Okay. All right. These ginkgo supplements, how long have you been taking this?
5 years.
Okay. What about the imipramine?
Imipramine and thyroxine has been there almost for the past 10 years.
Okay. All right. Sure. So, Mrs. Sandra, are you taking any hormonal medications or any traditional medications?
Hormonal? Yes. Thyroxine?
Oh, okay.
Traditional? No.
Yeah. Sorry. So, hormonal. As in, have you achieved menopause?
I'm 59, so menopause was happened about 3 years ago.
Okay. All right. Are you taking any hormone replacement for this condition, this menopause?
No.
Okay. All right. So, anyone in the family do having similar problems, Mrs. Sandra?
No, I don't think so.
Okay, sure. Do you have any allergies, Mrs. Sandra?
Yes, I am allergic to penicillin.
Okay. What happens if you take penicillin?
I'll have a little bit of rash whenever I consume penicillin. It's some reddish rash.
Okay.
Yeah.
Okay. So, have you been unwell recently that you require to see the doctor? That doctor give you some antibiotics? Are you aware of this?
No.
Okay. All right. Okay. So, Mrs. Sandra, I do have a partner.
Of course, I'm 59.
All right. How many kids do you have?
I have 2 daughters.
Okay. All right. What are you working as, Mrs. Sandra?
I'm a switchboard operator in the hospital.
Okay. And you mentioned that this has affecting your job, right?
Yes, definitely.
Okay, all right. So we try to figure this condition and try to help you out, all right? So, Mr. Sandra, do you smoke?
I used to, but I've stopped 6 years ago.
Okay. Do you drink any alcohol?
I've never.
Okay, that's good. So have you been traveling recently, Mr. Sandra?
No.
Okay. All right. So Mr. Sandra, can I examine you?
Sure.
Okay, just want to look at the general appearance of the Mr. Sandra. In any rash anywhere? Okay. All right. So I'm looking for, is there any particular scratch marks on her?
Yeah, a lot over the hands and tummy.
Okay, all right. Okay. So is there any signs of chronic liver disease such as spider nevi, any signs of Yeah, spider nevi.
No spider nevi.
Okay. Looking at the eyes, is there any jaundice? Okay. So then looking at the neck, is there any raised JVP?
Not necessary.
Okay. Moving on the chest as well, is there any form of rash over the chest?
What kind of rash?
Is there any blistering rash or any what is that? Any maculopapular rash?
Normal chest wall. On inspection.
Okay. Abdomen, is the abdomen distended? Okay. So is there any mass felt on the abdomen?
No palpable mass.
Okay. Is there any hepatomegaly?
No hepatomegaly.
Okay. So is there any shifting downwards of fluid trail?
No ascites.
Okay. Is there any leg swelling?
No leg swelling.
Okay, so I want to just ask back some questions to Mr. Sandra. Mr. Sandra, so I missed out some questions regarding your diet. Do you have any particular allergic to any diet or any taking any specific diet?
No, I take normal diet.
Okay, all right. Okay. So sorry, go back to the face. Is there any flushing of the face?
No flushing.
Okay, all right. Is there any abdomen? Is there any signs of caput medusae? Is there any splenomegaly signs of chronic liver disease?
No stigmata of chronic liver disease.
Okay. Checking back the hands, is there any rash over the extensor surfaces?
No.
Okay, all right. So so Mrs. Sandra, can I know what concerns you?
What am I having, doctor?
Okay, so Mrs. Sandra, so after getting a history from you and after examining you, I've noticed that there are a few causes that might lead to your rash, your itch. So one of the cause that comes to my mind, which I think strongly associated, it's regarding your liver, and the name is called primary biliary cirrhosis or primary sclerosing cholangitis, or something to do with your liver is. So I'll explain further about this. So don't mind the jargon. It's basically something to do with the tubes coming out from the liver, which supplies bile to the rest of your body. So in your condition, there will be some narrowing of the tubes that comes out from the liver, which in turn causing this itch and causing all your symptoms. All right.
Okay.
So okay, yeah. So
2 more minutes left.
yes. So I'd like to just do some blood tests for you and to arrange for an ultrasound scan of your liver, and at the same time get some x-rays done for you, and I will see you back again in the clinic probably in 1 week's time to see the results. So in the meantime, I will start you on some medications to help with the itch. And once the results are back, we'll start you on some specific medications to actually help with the condition and in return to relieve the itch. Is that okay?
Right.
Okay, so do you have any other concerns for me, Mr. Sandra?
No.
Okay, so Mr. Sandra, I'd like to summarize for you. Is that okay?
Sure.
So you mentioned that you're having this itch, which getting worse for 1 to 2 months, which occurs from the neck, which spreads to your tummy, right? And you notice that when you're doing a tattoo in the past, around the same time, the tattooists have told you that your eyes look yellowish, and you're also be suffering from some low thyroid hormone and some depression. All right.
Yeah.
I've told you that this could be due to the primary biliary cirrhosis, and I'd like to do some blood tests and to arrange an ultra scan for your liver. And we'll see you back in 1 week's time to look at the diagnosis and to
All
give
right,
some.
sure. Sure. Thank you. Thanks, doctor. Thank you. What's the diagnosis?
Okay, so after examining actually from Mr. Sandra, I think that my professional diagnosis for her would be primary biliary cirrhosis or pulmonary sclerosing cholangitis. As she's a middle-aged woman, having jaundice of the skin and also having itch, which is getting worse.
Right. Any differential?
Okay, so my difference will be I'd like to do some blood tests to rule out polycythemia vera, will cause itch also. And I'd like to do my intervention would be some dermatitis, and if possible, due to as well.
So were there any use of any chemicals that can trigger this dermatitis?
Yes, that is possible.
Do this patient have any use of any chemical that can trigger this dermatitis?
She has mentioned she has a tattoo done around the same time.
Okay, but any chemical use?
Chemical use
Will be explored further, isn't it?
Sorry, come again?
That will be explored further, isn't it?
Yeah, correct.
Any night sweats, doctor, in this patient?
I didn't ask about night sweats.
Is it relevant?
Yes.
Why?
Could be due to an underlying hematological malignancy.
Is it possible with all the symptoms that is presented?
Yes.
What malignancy you?
Could be due to lymphoma, or can be due to tuberculosis as well.
Any lymphadenopathy in this patient to suggest of them?
I didn't check for her on her.
Right. The patient was on a lot of medication. Is there any medication that can cause this problem?
The ginkgo that she took is a possible cause, and I'm not sure whether imipramine might cause as well or not. But however, she's been taking medication for 10 years already.
But you're very sure that thyroxine don't cause itchiness? Or you are not sure?
I'm not sure.
Okay. How would you investigate?
So I'd like to do a regular blood test, full blood count, a liver function test, and a renal profile. And at the same time, do a biohazard screening, hepatitis B, C, and HIV. I'd like to do some autoimmune screening for her, in particular anti-mitochondrial antibody, or looking at any anticipo muscle to indicate autoimmune liver disease. At the same time, arrange an ultrasound scan for her liver. I want to do a thyroid function test also to see how well the thyroid control, and arrange ultrasound of the hepatobiliary system. Is there any dilated ducts, or is there any signs of chronic liver disease or liver cirrhosis? Yeah. So
how about a peripheral blood film, doctor?
Yes, relevant. So if let's say her hemoglobin or her white cell count is high, such as lymphoma, I want to see any abnormal lymphoid cells or any increase in red blood cells.
Let's say if this is the case of lymphoma, how would you manage?
Okay. I would like to educate the patient and tell that this is a multidisciplinary approach. So I'd like to investigate further, do a full scan, a CT scan of the whole body, do a PET scan as well, and once confirmed, and with the blood test, such as PBF, and also do a bone marrow study, which see any bone marrow involvement. Subsequently, I'd like to refer this patient to the pathologist or
Okay, all right. Thank you. Right, so thumbs up. How is it? How do you feel?
Miss lymphoma.
Not really. You still have the diagnosis. It is definitely one of them. But you mentioned about PSC. So usually PSC, I agree that they are common in female and they presented with jaundice. But they commonly presented with pruritus.
So is this possible?
No, pruritus is not common in primary sclerosing cholangitis. They're common in female, they can have jaundice, but they usually do not have pruritus.
Okay.
So maybe not something that I will always say like interchangeable, like if there's PBC, there must be PSC. No. But on the other hand, PBC, there's a bit of discussion since you mentioned about this diagnosis. PBC is commonly associated with what other disease that you know?
Ulcerative colitis.
That is PSC, all right? So PSC is commonly associated with UC. So PBC?
It's an autoimmune condition, so it might be related to other autoimmune causes like thyroid, celiac.
Sjogren's syndrome and rheumatoid arthritis is commonly associated with PBC, whereas ulcerative colitis is commonly associated with PSC. So, well, if you're aware about that, then that's what I said as diagnosis etiology complication, but this is more like an association that you might want to find out further. Okay. But this case now, a bit of discussion. But before I go on to the discussion, just a little bit of my comment. That is number one. Just now you mentioned something like, do you have any skin rash or reddish bump in the skin? What do you mean?
Any purpose you mentioned itchiness, so let's want to clarify, is there any rash? Itchiness doesn't mean it's rash, so just want to clarify, is there any rash or not?
Okay, right. But I find that one thing that you need to be careful is no double symptom. Like example, do you have any shortness of breath or cough? I find that you always ask double symptom.
Okay.
So that can sometimes be difficult for the patient. I don't know which one to say yes or no, because you find that we always will just no for those that is negative or relevant negative issue of systemic review. So by doing this, do you have shortness of breath or this is very difficult. Okay. All right. So this is actually a case I want to demonstrate complexity. So this is exactly the scenario that I have in my own PACES exam, where this patient presented with pruritus, and exactly the same patient had hypothyroidism. He was on levothyroxine. Examiner wanted me to pinpoint the levothyroxine as one of the cause, and then the patient had allergy to penicillin. Yes, like you have rightly said, is there an allergic causes? Once there's pruritus, contact dermatitis is definitely not something you can not consider. So you need to ask further. Another one is the patient have back pain. The patient actually wants you to ask, like, so what is the medication that you take when you have back pain? The patient will, and in my actual scenario, so the patient was taking oxycodone. So it's a morphine based. So again, wanted you to think of morphine can cause pruritus. The night sweats and the if you would have examined, there may be a lymphadenopathy. So lymphoma is one. So primary biliary cirrhosis is another one. So at the end of the day, this scenario, I'm just trying to demonstrate complexity. So now that first case I did was giveaway, but you need to go in the details. But in this case, is be careful with cases where you can have a lot of differential. Then that is when you are not interested to go deeper. Like nobody is going to think what is the secondary cause of the PBC or secondary cause of the lymphoma. So in other words, you need to recognize what kind of cases that you need to consider secondary and what kind of cases you don't have to. Like if you have somebody coming in with very nice hyperpigmented mucosa, low BP, you want to think of Addison. But Addison's doesn't stop there. Why? TB, sarcoidosis, primary adrenal leukodystrophy, exogenous, secondary adrenal insufficiency. So these are kind of diagnoses that you need to consider the causes. But when this is the diagnosis, then you need to consider differential. Especially in this case, I definitely have to agree that it's very complex. Patient got comorbid, patient have allergic, which usually you don't have that complexity. Right? So this is where you need to do a little bit of writing so you don't miss out that important findings. Then only you don't miss out the differential. Okay? So otherwise, the PBC is definitely one of the differential, but like I think I've demonstrated to you that there are other differential. And not examining the lymph node is something that I find that can be quite major. So that is definitely not something that we want to do it again. But otherwise, yes, you got the PBC. Is it okay with you?
Yeah, right.
Okay. I want to know that. Do I have a lot of background noises now, or is okay?
Slightly distracting.
Is it? Yeah. Okay. Just now I'm alone, but now because I just came to a new place, I don't have a Wi-Fi, so I'm really pay, and the noise is probably accumulating. If it's too distracting, let me know. I see what I can do. Okay. We move on to the next station on communication, which I am extremely excited. Among all stations for PACES, I'm always excited for communication. So that's why those subsequent two more candidates, hopefully you will learn something. Okay, the next person who is doing.
I'm doing.
Okay, so are you ready?
Yeah.
Okay, so I will give you 5 minutes to prepare, or maybe I should just cut down because communication is now combined with your systemic examination, right? So I'll give you 3 minutes to prepare. You have 10 minutes with the patient. I will tell you when you have 2 more minutes. Is it okay with you?
Yeah, that's okay.
Okay, so I'll give you 3 minutes. Once you can see the slide, your 3 minutes begin. Can you see it already?
No. Okay, I can see it now.
All right. Alright, doctor. You can begin when you're ready.
Okay.
Sure.
Good evening. My name is Dr. Shakira, one of the doctors in the coronary care unit. May I just check that you are Mrs. Smith?
Hi, yes, hi, doctor. I'm Mrs. Smith here. What happened to my husband, doctor?
Mrs. Smith, I will answer all your questions shortly. But before we begin, is there anyone that you want to be present with you at the current moment?
It's okay. My son is still parking, but you can talk to me because I am the one handling my husband's health.
I see. Mrs. Smith, when was the last time you saw your husband?
We were having dinner together just now, and all of a sudden he just blacked out, and we call him. He turned blue, and then we tried to shake him. He was not responding to us. We were very worried about it. We called the ambulance, and then the ambulance actually brought him over immediately to the hospital. And after that, he was in the emergency department. You are the first doctor actually I am talking to.
I see. Mrs. Smith, I'll just pick up where you left off regarding what you know about your husband. So when he came to us, when I saw him in the emergency department, he was quite unwell actually. His blood tests and his investigations that we sent showed that he had a heart attack. And
Yes,
it
yes.
was
My husband is known to have heart attack. So, like, there was, I think, 5 years ago, he had a heart attack, and then the doctor actually gave some blood thinner and all. He stayed in the ward for like 5 days. Then I think he went on for some like mini procedure, and after that he was well. In fact, he's back to work and perfect. So he had another heart attack again. Is it, doctor?
Yes, Mrs. Smith. Unfortunately, he had another one, and as you know, patients who have had a second heart attack, most of the time it's more serious than their first heart attack. So in your husband's case, he was quite ill when he came to us, and we tried our very best. We gave him blood thinning medications to try and break up the clot that was causing the heart attack. Unfortunately, Mrs. Smith, the outcome is not as what we had hoped.
Okay. Seems like this time he had a more serious heart attack. But how is he doing now? Like, can I go in to check out on him?
Mrs. Smith, I think you need to prepare for the worst, because actually after we gave him the blood thinning medication, unfortunately his heart was in very bad shape, and he did not make it.
Okay, so what do you mean? So, like, have you all turn him over and do what you can? So what now, doctor?
Mrs. Smith, I really regret to inform you that despite our best efforts in trying to save your husband, unfortunately, he had succumbed to his illness and he has died.
Sorry, doctor. What did you say the last?
Mrs. Smith, I'm afraid I don't have good news, because despite our best efforts, your husband succumbed to his illness and he has unfortunately died.
Are you serious, doctor? I mean, he's just having dinner with us a few hours ago. How is it possible? I mean, are you sure are you talking about my husband?
Mrs. Smith, I was with him throughout his entire process. I was part of the team that tried our very best to save his life. Unfortunately, he was in very bad shape when he came to us, and his heart was.
I mean, he survived his previous heart attack. Why can't just the same happen again?
Unfortunately, Mrs. Smith, once a person has had one heart attack, there is some damage left to the heart, and a subsequent heart attack sometimes a person's heart cannot take that sort of insult. And in his case, I understand that he was strong to fight through his previous heart attack. Unfortunately,
are you sure that you have given him what he needed, like the best treatment, the necessary treatment? Like, were there any delay in giving the rescue to my husband? Because we have sent him very early to the hospital right after his collapse. It's a very quick period. We immediately sent him to the hospital. There was no delay at all.
Mrs. Smith, you and your family did everything correctly. You did everything right. The moment you recognized he was in pain, you brought him very promptly to the hospital, and we delivered our treatment as soon as we could, as soon as we saw him. But as I said, Mrs. Smith, his heart was already in poor condition, and unfortunately, he did not make it this time.
Oh my God! I mean, like, I can't believe this. I can't believe this.
Mrs. Smith,
I just want to know one thing, doctor. That at least tell me that did he suffer in that period when he was in the hospital?
The nature of heart disease usually is very quick, and after his after we gave the blood thinners, the process was very quick. I do not think he suffered.
I don't know what to say, doctor.
Mrs. Smith, I know this is probably not what you were expecting to hear, and I'm very sorry to be the one to break this news to you. But take all the time you need. Have a seat, and I will wait for the rest of your family members to come in, and I can get them to be with you. And if you need, I can also explain this to the rest of your family members as well.
I know that usually anyone who just passed away suddenly in the hospital need post-mortem, because one of my relatives, I think last week, had a traffic accident and he brought in death, and they did a post-mortem. So my husband did the same?
At this point, in terms of his cause of death, usually we carry out a post-mortem when we are unsure of the cause of death, or there's something that we would like to investigate. For his case, from the doctor's side, we are quite certain that his cause of death is his heart attack. However, if the family wish for a post-mortem for any reason, I will discuss with my consultant and get back to you on this. Is this something that you wish to pursue, Mrs. Smith?
Right. I mean, what can I do, right?
Mrs. Smith, may I know what is going through your mind right now?
2 more minutes. Well, I mean, he just told us that he wanted to travel together with us like next month during his birthday anniversary, and now this happened. And he's like the breadwinner of the family, you know, the main income earner of the family. How do you think we are going to survive now? 2 more minutes left.
Mrs. Smith, I understand. I can see that it's a very difficult time. I will do my best to try and help you and your family through this difficult period.
Okay, so what do I need to do next, doctor?
Once the nurses have finished attending to Mrs. Smith's body, we will gather the family, and you can see him. You can spend some time with him, and then afterwards, I will need to speak to you regarding what are your choices in terms of funeral rights. I will arrange some paperwork, and we can hopefully get him back to you as soon as possible. But in the meantime, your family can see him first.
Okay. Fine. Thank you, doctor. Right, time's up. So that's it. We don't have a discussion or anything like the past. So overall, how do you feel, doctor?
More difficult than I thought it would be.
More difficult.
Mm.
Oh, okay. Okay. You mean like what? Acting or the question or what?
Well, just hard to show empathy, but at the same time, we need to find out what is the hidden agenda from the surrogate.
Right. You are very well practiced, or you are new to it. But I'm definitely. I think I can see that you have been practicing well, right? Like going for exam very soon, right?
Yeah, very soon.
Yes. So definitely you're on the right track. I think this is definitely a clear pass. Okay, this is a clear pass for breaking the bad news station. You did everything correctly, except there's one more thing that if you can do it, that is what I call it as setting the scene. I always like to talk. I like to give these tips on this communication. Is always make the patient himself own words that later on you can use it back to counter your argument or your agenda or your task. So you wanted to make them realize that you were trying to say about second heart attack is going to be very bad, and actually I expect. I thought you would also say things like when the heart stops, the heart is a very important organ to pump the blood all over. So when the heart stops, means every part of the body will stop receiving blood, including the brain. And when the brain just deprived of oxygen, even for 3 minutes, they will eventually die. So that part is where we usually do. But I always like it if we make, if can, we make the surrogate themselves say it. So I will always like to start like that. Do you wish anybody to join us? Okay, so how was Mr. Smith before that? Do you think it's easier to counsel someone that is, oh yeah, he has been bedbound, he has been just lying on a bed, compared to somebody that if the surrogate said, oh yes, he was perfectly well, he's working, he's having dinner. So which one do you think there's any difference in terms of the expectation?
Yeah.
So I think even in reality, you know already what you are facing, so that you need to know how strong you need to set up it for. So asking about how they do before that is to assess. Then after that, you need to ask, so does Mr. Smith have any medical problems previously? I actually already trying to prompt you on that. So then you say, oh yes, I had a heart attack. He had a heart attack previously. Oh, okay. So what do you know about heart attack? So you prepare already. This is what I call setting the scene. Oh yeah, heart attack means. Also, do you know that when there's heart attack, actually the heart may even sometimes stop. Then maybe the candidate the surrogate say, oh yeah, possible. And as heart is a very important organ. You know why I do that is because it's very hard to say all this once you break the bad news. Do you agree? Once you say he's dead, nobody is going to listen all these things already. So you want to set the scene by doing this even before the breaking. Oh yeah, and you know that they are going to stop and then they will have received blood. And we know when the brain is a very important part of the body. Once they don't have oxygen, they will just lose consciousness. And sometimes they may even die. Then you wait and see what is his response. If he's like, oh, okay, then you know that he probably can accept. But if he's like still blur, then you know that you need to set it properly. Then you jump into the part that is to break the bad news. So this is also something that I use in counseling diagnosis. For example, when you need to counsel for renal biopsy, it's another difficult one. We need to emphasize by saying, so what do you think if we don't know what is wrong with the kidney? Then you say, yeah, maybe the kidney will fail. Oh, and do you know that if kidney fail, what will happen? Oh yeah, he may have to go for dialysis. I heard about this and that. Exactly. That's why I think the identification of the diagnosis is very important. Do you think so, madam? Yes. So that is why we are here today. I would like to talk to you about this procedure called renal biopsy. So rather than you go the other way around, madam, have you heard about renal biopsy? Oh, no, what is that? Oh yeah, renal biopsy is this because we need to do that. So that is a bit hard when you already throw the bomb. Then he will counter you back like, why do I need to do it? But if you already said, oh, that, then you said, remember, ma'am, that just now we have talked about the importance of knowing what is wrong, because by not doing the biopsy, we won't know what is the diagnosis. By not doing the diagnosis, I cannot give you the right treatment. Then he like it or not, he has to say yes because he has already agreed to you just now. He cannot be so nice just now and suddenly become a nasty person later on. So setting the scene is what I want to share with all of you in all your communication stations. you actually make the patient get anchored to one position. What is the stand that you want? You anchor the patient down, then you sell what you want to sell. It's always easier to sell your product. If they already said, do you think that this product is, or this phone is very good? Oh yeah, very good, everything very good. Then you say, so now do you want to buy? Of course, it's a bit hard to say no already. So that is what I mean. Otherwise, do you agree with me, doctor?
Yeah, I agree. It's
Yeah.
a better approach.
Yeah, so no hurry because 10 minutes. So usually we say 4 minutes. You can take 4 minutes to set the scene. Then you can do what you want to do after that. Okay, definitely this is a very anxious patient. So the examiner would like to see that you actually felt it. So you can say like, I can really see that you are very anxious, Madam Smith, Mrs. Smith. Are you sure you want me to continue? Oh, like that. So examiner want to see someone that don't care about pass and fail, but the patient more important. But in reality, we know that all the stunts and scripts we do is just to pass the exam. But you can say this, then the examiner know that you're not in a rush. So you can always, you sure you want us to continue? Something like that. So okay, that is for addressing the concern, the body language there. Don't avoid it. Don't avoid it. He's definitely very anxious. Okay. Warning shots. I think you did very well. The warning shots you definitely did very well. I'm something not good to tell you something. That is fine. Are you aware about silence? Are you aware about that?
Yeah.
Yeah, and you were practicing that, right?
Yeah.
Because I felt that. Okay, so I think any of you who listen to other tutor talking, and that is what I learned the most. I mean, one thing I learned a lot from that is silence in breaking the bad news. Once you break the bad news, you need to learn how to just keep quiet for 5 seconds. It matters. It shows you didn't care to just pass the exam. You want to give the information. So 5 seconds of silence. I think you practice that very, very well. It go on very naturally. Now, but one thing that I find that can improve is this. Don't use other words other than did. Did not make it, succumb. It's not a good term. The patient is dead. I'm so sorry. Pause. So because did not make it means what? Can means many things. Yeah? So just don't be worried about that word did. We need to use that word. Okay? All right. Are you sure you're talking about my husband? I think you did well. You said you were always with him throughout the whole thing. Okay. So that's fine. But he was trying to ask you this: were there any delay in the treatment? Do you think you have assessed it like fully, or you think you want to do it like better again on that part? Are you sure you have given him all the treatments? Like how do you think what else you have not mentioned?
No, not sure.
The resuscitation. So that is what he wanted to know. Like, yeah, Mrs. Smith, before I came out to talk to you, we actually have spent strong 30 minutes to bring your husband back. We had a team of people who did all we can, including intensive care and emergency doctor. We did cardiac massage. We have put in a tube into your husband. We have tried all we can. But as what we have discussed just now, when the brain do not receive blood in anything more than 3 minutes, usually are not reversible. So definitely we have given what we can, but I think what your husband experienced is too severe. So that is the part that we wanted to talk. You got that?
Yeah, got it.
Okay, so that is the one. Okay, cool. When he said that concern to you that, oh, my husband is a breadwinner, I'm not sure if you also thought about that, is to refer to the social welfare. Are you aware?
Yeah.
Yeah. So you mentioned that just now?
I said I'll help them, but they mentioned specifically social welfare.
Oh, okay. Because I heard that. I heard you saying that. I thought you wanted to give me some donation or what after the session or what. Okay. So financial is insurance and social welfare. Okay. Post-mortem. I think you have also answered that well. I think you are very ready for all these circumstances. Yes, this is not a sudden death. We know what is the cause. So definitely you do not need a post-mortem. And you have rightly said, but if out of family request, you can of course have it. So in this station, we always have questions that we have planted. I would like to just summarize the questions. That is one about sudden death. Number two is how come he did not survive this attack. Third was, what have you done? Have you tried all your best? And number four, the underlying concern that he is the breadwinner of the family. And finally, is the question on the post-mortem. And I think you did really well for all of this. Do you have any questions to ask, Doctor?
No, thank you very much, Doctor.
All right. I think that my background noise is very, very annoying. I just need one person to agree. Is it very loud?
It's very loud, Doctor.
Yeah. So, I'm sorry, I think the last person is, let me see, he's going to kill me, but I think it's not, is it? No.
I'm here.
Yeah, do you mind if we just push it if other time, or I can just do it like personally with you other time? Is it okay? And then I will record it and then I put it in the group. Is it okay?
Sure, no
Because
problem.
I think that the background noise is just unfair because it's very annoying. So I'm thankful that I have these three stations with all of you. I'm going to call it off as it's very noisy, but just a very quick summary on those. Any one of you are interested to go to the UK? Or I understand that now it's very difficult, right? It's very difficult. So, but I'll just give you a summary of if any one of you that is going. That is, it's a different challenges totally. The way you practice, and in terms of the presentation is usually not in rush. It's usually more calm, but it's not as concise and compact if you are planning to sit in Malaysia. So in Malaysia, you're expected to know everything because it's an exit exam, but in UK it's an entrance exam. So they just want to see how safe you are. So if you are going to UK, then you want to tune your talking towards them. That you are not Mr. Everybody, but you know where is your limit and who do you need to get involved in the management. We find that candidates who go UK will usually pass the diagnosis, but usually they will have problems with communications, concerns, and identifying physical signs actually compared to local candidates in the UK. So this is the statistics. So if any one of you planning to go, then improve on the way you present the case and how do you talk to the patient. Cases wise, it's just slightly a bit different. In like example, when I needed to go, I was looking a bit on liver transplant, cystic fibrosis, yellow nail syndrome for bronchiectasis, inflammatory bowel disease. In the UK, they're very particular about the word idiopathic pulmonary fibrosis, interstitial lung disease, because they're very advanced. So you want to know the difference between them. So this is just extra a little bit of cases that you want to know when you're going to there. I think that I'm speaking to just a very small population here that's going to UK, because I understand that nowadays they are restricting local, international candidates. But if anyone that is interested to go to the UK, you can of course find me personally, and I'm happy to share with you. Now I'm doing like this because I know that I am not going to be quite common in your platform, because I really salute Junmin for able to do this, because it's so complicated. Like I'm looking at the timer, I'm meeting people, and then I look at my PowerPoint. So I'm more comfortable to do the kampong style and a bit relaxed. But I'm very happy to join all of you today, and I wish you all the best in your exam. And if you have anything that you want to ask, feel free to let me know, and I'm more than happy to help you, and I wish all the best to you in your exam. So that's all from me. I shall pass it to Junmin, but I guess he is still not having his voice or what, but
Yeah, Xinghui, I can hear you. Yeah, sorry, I have to join halfway. I mean, I joined initially and then I somewhere have to go because I was busy. But I listened to your last scenario on the show, right? I mean, the CPR it was really a good station. I don't know where you get the scenario from, but I think the questions are actually not easy. So sometimes we can get this kind of scenario that is really difficult. That's why we need practice. And I can see that just now, yeah, I think it's Nick, right? Nick who done the scenario. Actually, you appears calm, and I think it's important for us to remain calm in exam, regardless of what kind of scenario that you're dealing with. Huh? And what Xing mentioned is very true. And the statistic also found that those UK candidates that went for exam, they tend to score very well in communication skill and in terms of maintaining patient welfare, but they are a bit poor in detecting physical sign as well as examination for some reason. As compared to our local candidate that went for exam, be it in the UK or in a Malaysia local setting, the examiner statistic shown that actually our local candidate is very good in finding the sign, examination, but we are very poor in communication skill. So perhaps it's because of different culture that we are being brought up, as well as what Xinghui mentioned, is because UK they're really focusing on the soft skill, the way how we communicate. So it's important for us to know all that, and that's why it's always good if Xinghui is free later on. I mean, in future, if he's free, I think he got a lot of things to share with everyone. I mean, just from the communication skill perspective, it's definitely not an easy station. Everyone will, I mean, when we start preparation for the PACES, right? Those seniors will say, communication skill, you just, you just show your empathy, you just goreng, and then that's it. But it's not as simple as that. You need to have some background knowledge, and you need to really know what are the things that is going to be discussed in a certain scenario. Sometimes the communication scenario, they will have some hidden agenda. And those hidden agenda, you will not get it unless you really ask more concern that the patient have and try to address more and more concern, that you realize the patient will reveal more and more stuff. So it is possible. But generally, don't be worried. I think nowadays the scenario tend to be, we won't know because this is the first diet they are doing this. But they have promised us that this comp skill is nothing different than the old format in terms of the team, like what we discussed yesterday for those who joined. So just continue to practice the team. The most important thing is to practice the team. And at the same time, towards the last, I believe those that are going for October got only 1 month left, right? So within 1 month of the exam, it's very important to spend some time to really examine some short cases. It is really a time for you to refresh some short cases. You want to go for any like very classical, you want to go for asking your consultant to teach with those that have a good sign and do a proper exam. This is the time to really do it, because towards the last 2 weeks of exam, I tell you, hardly ever got anyone want to examine patient anymore. Everyone is so stressed out. Everyone just want to, swallow everything that, those approach, go through the some of the knowledge and also com skill, practice here and there. So can be very stressful. But if you time it yourself at this point of time, if you time it like, okay, you tell yourself that maybe for these 2 weeks, the first and second week, I will just focusing more on the practice, the short cases. Then the last 2 weeks, I will just focusing on revising, and then also